Friends, it's a pleasure to be here. Thank you for the invite. And let me begin my talk on self-limiting thyrotoxicosis. It is well known that hyperthyroidism is common in India. Studies have shown that the prevalence of overt hyperthyroidism is about 0.67%. And this will be my agenda for today. I will introduce the case, uh, look at some differential diagnosis, and end with some practical tips for management. So here's a 41-year-old lady, 8 weeks post-COVID. She then develops fever, a thyroid swelling in the neck with pain for 5 weeks. If you look at her thyroid functions, it's very clear that the free T3 is high, the free T4 is normal, and the TSH is low. The nuclear scan, as you can see, shows no uptake in the neck, and this is a classic case of subacute viral thyroiditis causing a T3 kind of toxicosis. So I've looked at my beginning with a case study. Let's look at the differential diagnosis and causes of temporary or self-limiting hyperthyroidism or thyrotoxicosis. So if you just take this example of COVID, the three reported effects of the coronavirus are COVID-19 are thyrotoxicosis. This could be either subacute painful thyroiditis, or it just could be a painless atypical form of thyroiditis without any pain. COVID is also associated with hypothyroidism, that could be central or primary. And as we know, COVID can also be associated with non-thyroidal illness syndrome, where the thyroid function tests may be abnormal because of a coexisting severe illness. So one of the effects of the coronavirus, is direct damage to the thyroid gland. But there are other explanations also. The thyroid cells have been selectively, the receptors in the thyroid cells selectively have seemed to sort of attach to the coronavirus, because the ACE2 TMPRSS2, you will know that the ACE2 receptor on cells attaches to the coronavirus, and so the COVID-19 virus may attach to the ACE2 TMPRSS2 pathway, which is selectively expressed in the thyroid cells. So that could be another. It's also important to know that the structural proximity of the virus-laden superior airways to the thyroid gland. Remember, the coronavirus or COVID-19 affects the respiratory system, the upper respiratory system, and this is physically and structurally very close to the thyroid gland, and that could play a role as well. We know that lots of vitamins are nowadays taken by patients in the hope that it will improve immunity, and some of these may contain biotin, and that can also interfere with thyroid function test, and we'll come to that. And the third is non-thyroidal illness conditions such as inflammation, sepsis, and steroids can also disrupt thyroid function tests. So these are the four largely important causes of self-limiting thyrotoxicosis. One is, as you can see, subacute thyroiditis. Second is hashitoxicosis. Even less common is trauma to the gland. It could be surgical trauma, certain drugs, palpation, hemorrhage into a thyroid gland. All these direct structural damage to the thyroid gland can lead to a temporary release of thyroid hormones. Remember, thyroid hormones have a half-life of 6 to 7 days, and it takes 6 to 7 half-lives of the drug to be washed away. So the thyrotoxicosis, because of direct thyroid damage, is usually self-limiting unless the damage is ongoing in some other ways. Like, for example, if there is a coexisting Graves' disease or something like that. Rarely this kind of thyroiditis can also persist for long, but usually it's self-resolving. Very rare to see spontaneous resolution of Graves' disease, which can occur, and also important to remember biotin interfering with tests. Now, is it really thyrotoxicosis? That's the first thing we must be asking in clinical practice, and the biochemical thyrotoxicosis that you see on biotin is temporary. I call it biochemical because it does nothing clinically. Biotin interferes with the thyroid function testing protocol in the lab, and therefore it can cause laboratory thyroid functions to be deranged. So here's a 45-year-old gentleman who took a health checkup package. He's on biotin supplements for his baldness. And what was seen in this gentleman was that the free T3 is high, the free T4 is high, the TSH is extremely low, 0.0001. Can TSH receptor antibody help in these cases? No, because biotin can also interfere with TRAb measurements, as we will see. What is the management of these patients? It is careful follow-up, and important, friends, to note that drug-induced thyroid disease is underrated. So this is a very interesting publication published in 2019 May, where they studied the thyroid function test of a 41-year-old adult endocrinologist who volunteered to be administered biotin 30 milligrams per day for a week. Now, the biotin minimum interfering dose, the minimum dose of biotin that interferes with the thyroid function test is 5 mg. But this gentleman, this endocrinologist, took 30 mg, and you can see that on biotin, his TSH was low at 0.8. It was 1.45 the TSH, it came down to 0.8, and off biotin it is 1.33. Similarly, the free T4 was 1.36 initially. After taking biotin, it shot up to 1.94 and it came down to 1.24 24 hours after stopping biotin. So the T3 also went up with biotin and came down after stopping biotin. But what is important is that the anti-TPO and the TSH receptor antibodies also shot up after taking biotin and went back to normal levels after biotin was stopped. The biotin streptavidin is a reaction which is used in the laboratory in the measurement of thyroid hormones. So it's very important that biotin can actually interfere with thyroid function tests, and we as doctors should know it. And as you can see, it's important to stop biotin at least for 2 days and test thyroid functions. But if you are doing TSH receptor antibody, you need to wait for a week after stopping biotin. So important to note that we must not label a patient as thyrotoxicosis on biotin, because the T3 may be high, T4 may be high, TSH may be low, and even the TSH receptor antibody may be positive. So important to remember that. So there are two other things to remember when we look at self-limiting or self-resolving thyrotoxicosis. The first is Hashimotoxicosis. There are several definitions of Hashimotoxicosis, bit of a controversy. So this is an article, a commentary I wrote many years back on Hashimotoxicosis. Generally, it refers to Graves' disease with Hashimoto's thyroiditis. So patients present with thyrotoxicosis, but they remit very early. How do you diagnose it and differentiate it from classical Graves? Because the gland is very firm. The TPO antibodies are very high. Now, if you do a nuclear scan in Hashimotoxicosis, yes, there may be an increased uptake, but the uptake increase is only a slight increase on technetium scan. And there is no sparkling, intense vascularity on Doppler. There may just be a little bit of a high vascularity. So these subtle features should differentiate Hashimotoxicosis from classical Graves' disease. Why is it important to differentiate? Because once you differentiate, you will know the cause better. Hashimotoxicosis is often, once you treat with antithyroid drugs, you can taper and stop it fairly quickly. On the other hand, it's also remembered to understand that the TSH receptor antibody is two-faced. We know that the TSH receptor antibody binds to the TSH receptor, but it can stimulate or block. If it stimulates, it causes thyrotoxicosis, and if the TSH receptor antibody blocks the thyroid gland, it can cause hypothyroidism. And it's also important to note that this stimulating antibody can change into blocking antibody and vice versa. So sometimes thyrotoxicosis due to Graves' disease with TSH receptor antibodies can not just resolve, can also be replaced with hypothyroidism. It's also important that in neonates where there is thyrotoxicosis, when the mother's TSH receptor antibody goes to the baby can get a temporary toxicosis. And when these IgG antibodies disappear, the thyrotoxicosis in the baby will get better. It's also important to note that our current assays do not differentiate between TSH receptor stimulating antibodies or blocking antibodies. It will only measure the TSH receptor antibody, and it's left to our clinical sense to actually take care of the real diagnosis. So I've looked at the introduction, I've looked at some differential diagnosis and causes. Now let's look at some of the management practical tips. As I said, one of the important things in thyrotoxicosis is to find out whether it's really a thyrotoxicosis. Is it a sick thyroid syndrome or non-thyroidal illness? Is it that the TSH is suppressed because of some condition like, say, pregnancy? Is it biotin? If none of this is there, is it subacute thyroiditis? Does this patient have pain and tenderness in the thyroid gland following a viral infection? Sometimes atypically it may not even be there. The pain may not even be there. Is it hashitoxicosis? Is the gland firm and is the uptake just slightly high? Does it have atypical features? And wherever you are in doubt, it's important to follow up the patient without really treating. And you can just follow. So some tips here. One is please look for biotin, rule out a lab error and retest, go by your clinical acumen. Remember that some trauma to the thyroid gland, like for example, a hemorrhage into a nodule, can cause temporary thyrotoxicosis that can get better. In today's pandemic era, COVID has to be considered. Sometimes when there is very painful, tender, subacute viral thyroiditis, steroids may help. Remember the two-phased TSH receptor antibody, that it may be blocking to stimulating and thyrotoxicosis may remit. In many cases, masterly inactivity and careful follow-up is enough, and time will tell whether the thyrotoxicosis will remit. So some of the cases of thyroiditis may last for a longer period of time, so you can carefully treat and see. But always, whenever you start anti-thyroid drugs for patients with Graves' disease, please look for an early remission, because some of these cases, as discussed, can remit very early. It's a pleasure discussing this topic with you, and thank you so much for listening to me. And it's a pleasure being here virtually. Thank you very much.